Typhoid fever, also known as enteric fever, is a potentially fatal, multisystemic illness caused primarily by Salmonella typhi and to a lesser extent by Salmonella paratyphi. With proper treatment, enteric fever yields a high cure rate. But, untreated typhoid fever may progress to delirium, which is an abrupt change in the brain that causes mental confusion and emotional disruption. Intestinal obstruction, intestinal hemorrhage, bowel perforation, and death within 1 month of onset of the disease. Most common transmission method of typhoid fever is oral transmission via ingestion of contaminated food and beverages. These food handlers are often asymptomatic and they chronically shed the bacteria through feces or, less commonly, urine. Due to poor personal hygiene of these people, food is often contaminated with bacteria. Bacteria can also be transmitted by drinking sewage-contaminated water and eating shellfish. And neglecting hand hygiene after using a contaminated toilet is another method of transmission. Typhoid fever occurs worldwide, primarily in developing nations whose sanitary conditions are poor. Typhoid fever is endemic in Asia, Africa, Latin America and Caribbean, which are colored in red color on the map. Travelers who are traveling to these endemic countries are at high risk of developing typhoid fever. Typhoidal salmonella are able to survive a stomach pH as low as 1.5. Reduction in gastric acidity may increase the risk of developing typhoid fever. Antacids, proton pump inhibitors, H2 receptor blockers, gastrectomy and conditions like achlorohydria can cause reduction in gastric acidity and facilitate bacterial growth. And some people may possess genetic polymorphisms, which dampen the macrophage activity and facilitate bacterial growth. Now let's discuss about the pathophysiology of typhoid fever. All pathogenic Salmonella species, when present in the gut, are engulfed by phagocytic cells, which then pass through the mucosa and present them to the macrophages in lamina propria. Non-typhoidal Salmonella are phagocytous throughout the distal ileum and colon. With toll-like receptors, macrophages recognize pathogen-associated molecular patterns, such as flagella and lipopolysaccharides. Macrophages and intestinal epithelial cells then attract T cells and neutrophils with interleukin 8, causing inflammation and suppressing the infection. In contrast to non-typhoidal Salmonella, Salmonella typhi and paratyphi enter the host system primarily through the distal ileum. They adhere to the epithelium over clusters of lymphoid tissue in the ileum, also known as Peyer's patches. They have specialized fimbriae to adhere to the epithelial cells. The bacteria are then phagocytized by the macrophages located in Peyer's patches. The bacteria then induce their host macrophages to attract more macrophages. Salmonella-containing macrophages then reach the mesenteric lymph nodes, thoracic duct and reticuloendothelial system, which consists of liver, spleen, bone marrow and associated lymph nodes. While traveling, bacteria use the macrophage cellular mechanisms for their own reproduction. Once a critical density of organisms reached, they induce macrophage apoptosis, breaking out into the bloodstream to invade rest of the body. The bacteria then infect the gallbladder via either bacteremia or direct extension of infected bile. The result is that the organism re-enters the gastrointestinal tract in bile and re-infects Peyer's patches. Bacteria that do not re-infect the host are typically shed in the stools and are then available to infect other hosts. Now I'm going to discuss about the signs and symptoms of classic typhoid fever. The clinical syndromes associated with Salmonella typhi and paratyphi are indistinguishable. Thus, both organisms generate a similar type of clinical presentation. Signs and symptoms usually appear after 7 to 14 days of ingestion of the bacteria. Fever pattern is stepwise, characterized by rising temperature over the course of each day that drops by the subsequent morning. The peaks and troughs rise progressively over time. Relative bradycardia and reduced pulse pressure can also be observed. Over the course of the first week of illness, the notorious gastrointestinal manifestations develop. These include diffuse abdominal pain and tenderness, and in some cases, fierce right upper quadrant pain. Monocytic infiltration causes inflammation of Peyer's patches. This may lead to narrowing of bowel lumen, causing constipation that lasts the duration of the illness. In addition, the patient may present with a dry cough, dull frontal headache, delirium, and malaise. At the end of the first week of illness, fever plateaus at around 39 to 40 degrees Celsius. The patient develops rose spots, which are salmon-colored and 1 to 4 centimeters in size. These generally resolve within 2 to 5 days. During the second week of illness, the signs and symptoms listed above progress. Abdomen becomes distended and splenomegaly is common. Relative bradycardia and necrotic pulse may develop. In the third week, the individual grows more toxic and anorexic with significant weight loss. The conjunctivae are infected. And the patient is tachypnic with a thready pulse and crackles over the lung bases. Abdominal distension is severe. Some patients experience foul, green-yellow, liquid diarrhea, also known as pea soup diarrhea. Inflammation due to the necrosis of Peyer's patches may cause bowel perforation and peritonitis. At this point, overwhelming toxemia, myocarditis or intestinal hemorrhage may cause death. If the individual survives to the fourth week, fever, mental confusion and abdominal distension increases over the next few days. Intestinal and neurologic manifestations may still occur. Weight loss and weakness increases. Some survivors become asymptomatic salmonella carriers and have the potential to transmit the disease to other people. The clinical course of a given individual may deviate from the above description of classic disease. The signs and symptoms may vary depending on the geographic region, race factors and the infecting bacterial species. The stepladder fever pattern that was once the hallmark of typhoid fever now occurs only about 12% of all cases. In most recent cases, the fever has a steady, insidious onset. Young children, individuals with AIDS, and 1/3 of immunocompetent adults with typhoid fever develop diarrhea rather than constipation. Now let's discuss about the complications of typhoid fever. As it is a multisystemic illness, it affects almost all the organ systems in the body. Potential neuropsychiatric manifestations include the following: a toxic confusional state characterized by disorientation, delirium and restlessness. Facial twitching and convulsions. Stupor, obtundation, and coma indicate severe disease. In rare cases, transverse myelitis, clinical mononeuropathy, and polyneuropathy may occur. Spastic paraplegia, peripheral or cranial neuritis, Guillain-Barré syndrome, and depression are some other rare complications. Respiratory complications may include acute lobar pneumonia and ulceration of the posterior pharynx. Cardiovascular complications may include toxic myocarditis in about 1 to 5% of patients. This is the leading cause of death in endemic areas. And rarely, the patient may develop pericarditis. Hepatobiliary complications may include jaundice, pancreatitis and hepatomegaly. Intestinal manifestations include intestinal hemorrhage and perforation. Genitourinary manifestations include immune complex glomerulitis, proteinuria, and rarely, nephritic syndrome. Hematologic manifestations include disseminated intravascular coagulation and rarely, hemolytic uremic syndrome. The diagnosis of typhoid fever is primarily clinical, based on history and signs and symptoms. The doctor should obtain a travel history from the patient. In addition, culture of the organism should perform to confirm the diagnosis and test antibiotic sensitivity. Culture of the organism is considered 100% specific. Blood, intestinal secretions, and feces can be used to isolate the organism. Now let's discuss about possible treatment options for typhoid fever. Untreated typhoid fever carries about 15 to 30% of mortality rate. However, with proper treatment, the mortality rate of typhoid fever is less than 1%. Carefully consider empiric treatment options. Most Salmonella typhi and Paratyphi strains are not susceptible to fluoroquinolones. Thus, fluoroquinolones should not be included in empiric treatment. As CDC indicates, azithromycin for suspected uncomplicated disease and third-generation cephalosporins for severe or complicated disease are given. People who traveled to Pakistan are treated with different antibiotics. Azithromycin for uncomplicated disease and carbapenems for severe or complicated disease. Finally, let's come to the prevention of typhoid fever. Maintaining of good personal hygiene is a good way of prevention of typhoid fever. Vaccination is recommended for travelers to parts of the world where typhoid fever is common. People who live in endemic areas. And laboratory workers who work with Salmonella typhi bacteria. There are 2 vaccines are available for typhoid fever. Inactivated 1 and live attenuated 1. Inactivated vaccine is given as an intravenous injection and given to people of 2 years and older. A single-dose vaccine, given 2 weeks before travel. Repeated doses are recommended every 2 years for people who remain at risk. Live attenuated vaccine is given orally as a capsule and given to people of 6 years and older.